Hello and welcome to Perimenopause as a Tipping Point, navigating the neurological and metabolic shift. My name is Adair Anderson. I am the product marketing educator here at Vibrant Wellness, and I'm pleased to introduce you to Dr. Lara Briden. Dr. Briden is a naturopathic doctor with a background in evolutionary biology and nearly 30 years of clinical experience. After working as a researcher at the University of Calgary, she completed her medical training at the Canadian College of Naturopathic Medicine. Dr. Bryden is widely recognized for her expertise in women's health and the use of nutrition and lifestyle strategies to support ovulatory function and hormonal balance. She's the author of the Period Repair Manual, Hormone Repair Manual, and Metabolic Repair for Women, and has published peer reviewed research on ovulatory disturbances and individualized approaches to PCOS. She currently practices in Christchurch, New Zealand, where it's currently 10 a.m. on Tuesday morning. Take it away, Dr. Bryden.
Thanks, Adair, for such a lovely introduction. Yes, I'm one day in the future, and it's also winter here. Everything is upside down here. I wouldn't be surprised if we have some Australia or New Zealand clinicians in the audience today too. So welcome, and yeah, thanks for such a great introduction. So I am a formerly evolutionary biologist. That'll shine through a little bit in some of the content today, and I'm Canadian originally. So that's the accent, even though I now live down under. I spent a lot of years in Sydney, Australia as well. So today we're going to explore perimenopause, which, as you probably know, if you've been anywhere near social media, it's having a bit of a moment. It's there's a lot going on with perimenopause, and I would venture to say there's quite a lot of confusion about a few aspects of it. So hopefully today will clear up some of that confusion. So let's just start with some definitions, which I know is boring, but we do need to talk about this a little bit because perimenopause, because of the terms that are being used. So perimenopause is the 2 to 10 years leading up to menopause or postmenopause. Now the confusion comes in that perimenopause, another sometimes gets called the menopause transition. That's mostly coming out of the UK, or just the menopause, which is actually confusing because perimenopause and menopause or postmenopause are entirely different from a hormonal perspective and a health perspective, really. Um, as we're going to see, especially the early phases of perimenopause are a time of high estrogen, whereas menopause or postmenopause, depending on what you want to call it, is a time of low estrogen. So it's yeah. So the definition I like is that menopause or postmenopause is the life phase, hopefully like a 40-year life phase that begins 1 year after the final period. All right. So, but today we're mainly talking about perimenopause. So these are the concepts I'm going to present to you. They're another way. They're sort of reframings of perimenopause. So one, there's been this narrative out there that menopause is new because we all used to die by 45. That is just absolutely incorrect, which I'll present. And I'm pretty passionate about this because of my background in evolutionary biologist. And once a biologist, always a biologist. There's a quote that I love, which is that quote, "Nothing in biology, and I would say health, makes sense except in the light of evolution." So the second reframing, we're going to go through each of these one by one, but the second reframing is that perimenopause is a recalibration or a rewiring of every system, especially the nervous and metabolic systems. And that recalibration can be a tipping point for long-term health. And the third reframing is that as I said earlier, the early phases of a perimenopause are a time of high estrogen, not low. This is crucial clinically, as you can imagine. So before we get to all that, I'll just quickly point out what I consider to be the official symptom list for perimenopause, excuse me. This list is from my colleague, Canadian endocrinologist, Professor Geraldine Pryor, who we're going to meet a few times today. She's quite a close colleague of mine. We've written a couple of scientific papers together, and one scientific paper together, and I've worked with her on some other projects, kind of behind the scenes. And yeah, so she's a giant in women's health. So this is her list as an endocrinologist, and I think this is pretty spot on. These are the list of symptoms you'll be hearing from your patients. So heavy or longer menstrual flow, increased period pain, a shortening of the menstrual cycle initially. That's because of the high FSH. New, sore, swollen, or lumpy breasts. Women say they feel pregnant with their breasts, weight gain, and that is spoiler. We're going to talk about that. That's the shift to insulin resistance that happens with perimenopause. New mid sleep waking, night sweats, usually premenstrual. Migraines can flare up and worsening of mood swings. So these can also be used to assess perimenopause. And indeed, I would say this is really one of the best ways to assess it. Maybe that or cycle charting. We'll talk about that in the assessment section. But according to Professor Pryor, the assessment pathway would be a midlife woman, so older than, mid 37, 38 into her 40s. If she's likely to be in perimenopause if she has at least 3 of these 9 symptoms and other explanations for those symptoms have been ruled out. So it's a diagnosis of exclusion. That's true even if she's having regular cycles. And this is crucial because there's no blood test. There's no any kind of test for perimenopause. As we'll see, it's really because perimenopause itself is actually just sort of a maladaptation or reduced ability to adapt to a normal hormonal shift. So now, of course, this list only applies to women who are having natural menstrual cycles. Hormonal birth control masks everything. That's true for almost anything in women's health. So that would be a whole different lecture. And also, Professor Pryor says, and I agree, that hormonal birth control in general is not a good choice for women in perimenopause. The exception to that might be the hormonal IUD, which we can talk about in the questions. Right. All right. So on to the first concept of reframing. Oh, right. Sorry. That was, yeah, it can be used to assess. So menopause evolved and is not an accident of living too long. In this fascinating paper, I've given you the citations there, Postmenopausal Health and Disease from the Perspective of Evolutionary Medicine. Biologist Andrew Froyle makes the case that I love this quote. Oops, sorry, that the human female body has evolved to function and remain healthy for a substantial period of time, decades after menopause, despite the accompanying reduction in circulating estrogen. We're unusual for mammals in this regard. We've evolved it specifically. So the paper contrasts the estrogen deficiency narrative with the more biological accurate evolutionary medicine analysis. So, for example, so in the deficiency narrative, which I'm trying to debunk, estrogen decline at menopause is a deficiency, like sort of somehow equivalent to thyroid hormone deficiency or something, or insulin deficiency. It's not that. Estrogen decline in humans is adapted. I'll just say it is adaptive. I'll just say at this point that doesn't rule out using estrogen therapy. So we can definitely, I'm generally supportive of estrogen therapy, so we can talk about that. But I also do feel like we need to understand things properly from a scientific perspective. There are reasons why in the modern world we might need estrogen more than our ancestors did, for example. Going down the list, in the old deficiency narrative, post-reproductive decades are an accident of living too long. Incorrect. What we know from various lines of evidence is that a longer post-reproductive, what they call somatic lifespan, was selected for specifically in females, likely. But males get the benefit of that longer lifespan as well because we share genes with them. So, and then in the deficiency narrative, symptoms and disease risk are from low estrogen, straight up. That's sort of the one narrative. But what I'm going to present to you today is that symptoms and disease risk associated with perimenopause and menopause are from a reduced ability to adapt to a normal transition as a result of modern factors. This is a concept called evolutionary mismatch. It applies to lots of things in medicine. You might have come across that term before. So what are those modern factors? You won't be surprised by many of them, but I'll start with this. In our modern day world, for different reasons, we, through our reproductive years, we have much higher overall estrogen exposure. It's a lot to do with the modern diet promotes higher estrogen to do with changes with the microbiome, and also just from a life history perspective, we spend on average, I mean, there's exceptions obviously, but most women spend less time in the very low estrogen state of breastfeeding or lactational amenorrhea. So our ancestors would have spent years and years in a low estrogen state. of breastfeeding. And all of that can make for a much more difficult transition to low estrogen. So just to give you a scenario, I mean, the traditional scenario was and probably was and still is in many cultures like the Hadza in Tanzania. You have a final baby by, age 42, something like that. You breastfeed for a few years into your mid 40s, and then you quietly just cruise from that to just never getting another period. So in that scenario, women really only had to transition from the low estrogen, high oxytocin state of breastfeeding to the lower oxytocin state of menopause. And it's a lower estrogen state. I'll just point out it's not zero estrogen. We still have quite a bit of estrogen around, even in the menopausal years or the postmenopausal years. So that's obviously quite a different thing from what we're going to see is, women trying to transition from a really quite high estrogen state of modern perimenopause. And the role that oxytocin might play in mitigating the effects of low estrogen is fascinating. And actually, oxytocin is being researched as a symptom. Oh, sorry, as a treatment for perimenopausal symptoms. So next on our list of modern factors, again, as natural health practitioners, none of this is a surprise, but of course, environmental toxins have played a role, without a doubt. So this is I've provided there. It's a 2024 review, which looked at how a lifetime, not just in the moment exposure, but a lifetime of exposure to things like phthalates and fluorinated substances, tends to bring menopause potentially a little bit earlier, but also intensify the symptoms of the transition. So again, it's not just current toxins, it's past toxins. There's a couple of citations in my perimenopause book about fascinating, a couple papers about how those of us in Gen X who were kids in the 70s when there was leaded gasoline and leaded petroleum and lead from other sources were exposed to quite a bit of lead in those decades. And of course, you sequester lead into your bones. And then with the increased bone turnover of especially the later phases of perimenopause, lead is released. And so these couple of papers about how at least some of the neurological symptoms of perimenopause could be from exposure to lead from our own bones. And as you can imagine, previous my ancestors wouldn't have had to deal with that. Other really obvious factors like alcohol plays a big role in symptoms, the health of the microbiome, the health of circadian rhythm, because circadian rhythm changes with this shift in female hormones, the amount of physical activity, and of course, all the ways the modern food environment pushes everyone into insulin resistance, except that women in their reproductive years, women with high estradiol are sheltered from that to some extent. So I'll present a bit more about that. But just to reiterate, I'm trying to build the case that this transition is a normal life event. It should be no more symptomatic than any other transition, such as postpartum or puberty. But in our modern world, because of evolutionary mismatch, all of those transitions, including perimenopause, can be symptomatic, often are, although not always. And I've just been sharing. I had such a jarring moment in social media a few months ago. Someone said, it just made me really realize, the narrative has gotten out of control when it comes to perimenopause. Because her comment was something like, she said, okay, so I'm 47 and I'm clearly in perimenopause. My periods are becoming farther apart by that point. She said, "But I feel fine. I have no symptoms. Does that mean something's wrong with me?" And I'm like, "Oh, no. Oh, dear. We've really gone off the rails if women feel like they should be suffering symptoms when they're not." So this is, it's very analogous to how there's a narrative that periods themselves are inherently symptomatic. They're not. It's totally normal to just get a period that arrives with no premenstrual mood symptoms, with no pain. Just, we're evolved to do this. Right. So let's keep going. Let's look at the second concept or reframing. It's a recalibration. This is really clear in the scientific literature. There's no doubt about this whatsoever. Specifically, it's a recalibration of metabolism, metabolic health, the immune system, and the nervous system. And we don't have time today to go into immune recalibration, but it's a pretty fascinating area itself. This is why autoimmune conditions can flare during these years, some types of autoimmune. But we're gonna really talk about the other two, metabolism and nervous system. So starting with this, um, I showed you this paper, the citation for this in the sort of modern factors slide a couple back. But this is a study called Menopause is Associated with Postprandial Metabolism, Metabolic Health, and Lifestyle. And they found that women okay, and this is a UK paper, so this is where you get um, the kind of conflating of the terms. So women in the menopause transition, AKA perimenopause, not postmenopause, um, well, some of this will continue into postmenopause, but the point being, these things, the shift happens during perimenopause. So increased fasting insulin, higher HOMA-IR, increased triglycerides. This is all looking quite familiar to you. High hunger. Um, this is insulin resistance. This is in line with the fact that other studies have found that visceral fat, specifically that compartment of fat, can increase by 50% during the perimenopause transition, even when BMI remains constant. So it's a very significant change in fat distribution, body shape, thickening around the waist. Um, One author of the study from King's College London described the menopause transition or perimenopause as, quote, a time of major metabolic upheaval. Now, importantly, in this paper, they do say that they note that the most significant rate of change to metabolic health occurs during perimenopause, but then stabilizes postmenopause, which is great news. So you can say to your patients, if they feel like, what the heck is happening to my body? What is going on here? You can assure them, well, you can help them, I mean, treat them, but also assure them things are going to stabilize into the postmenopause years. It's not going to keep going like this. So next, let's look at recalibration of the nervous system. This paper had a huge impact on me when I read it. I realized, I think now it's actually almost 8 or 10 years old. I read this paper heading into writing my perimenopause book, but this is a paper called Perimenopause as a Neurological Transition State. It's by neuroscientist Lara Briden, who's a close colleague. Well, she's collaborated with Lisa Mosconi, another neuroscientist who's quite famous in this space. So in this paper, she argues very eloquently, I feel, that the symptoms of perimenopause are largely neurological in nature, including vasomotor, sleep disturbance, reduced ability to cope with stress, migraines that we saw in Professor Pryor's list. She doesn't talk about migraines in this paper, but I feel like that should be there. So in this paper, she defines a neurological transition state as a state when, quote, a fully functioning neurological system undergoes a conversion from one state of developmental aging to another. So conversion from one state to another is recalibration, which is the word I use in all my writings. I also talk about brain rewiring in my book. I give the analogy, it's like a software update on the computer. So things can get a little glitchy during the update. It tells you, do not, make sure, leave your computer plugged in, do not turn it off, do not do anything dramatic while it's happening. But once you come through the update, you should be good. So she compares very logically, I think, perimenopause to the other major neurological transition states that we undergo, particularly puberty, which is also associated with neurological symptoms. But so this is why I call perimenopause second puberty. And if you think about it, like when kids are in puberty and their moods are changing and their brain is changing, you don't think, oh, this is how they're always going to be now. It's analogous for women. This isn't how women are always going to be. My patients are so relieved to know um, that, I mean, hopefully, well, there's treatment, there's help for how they're currently feeling, but also it's all going to settle down and stabilize. So, one of the major aspects of this brain recalibration is closely related to the metabolic recalibration that we just discussed. And so, this is what Brinton coined the term brain energy crisis. She talks about it in another paper that I'm just about to show you. So, um, oh no, it's the same paper. Yeah, the perimenopause as a neurological transition state. She says that estrogen receptor network becomes uncoupled from the bioenergetic system during the perimenopausal transition, and a hypometabolic state associated with neurological dysfunction emerges. It's very confronting, actually, to sort of know that the brain is going into this kind of glitchy time. But as women, it's quite confronting. But it's better to just sort of face what's happening and also to understand. Actually, one of her papers, one thing I read by Brinton, she does, and I think one of her interviews, she talks about how even despite this sort of glitching that women can get, some women can get in their um, cognitive function, they still, often outperform men on many of the cognitive markers. So I don't know how many men are in the audience. That's not a dig at men at all. It's just a way to reassure women. So in a 2021 paper with Lisa Mosconi, she explains what we should all know, that estradiol normally enhances insulin sensitivity via several mechanisms, including by being very supportive to mitochondria and their ability to turn glucose into energy. So when estradiol reduces, cells have to adapt. They have to recalibrate. They have to partly switch. They have to partly switch or sort of turn the dial from burning glucose to burning fat and ketones. And as they say, in one of their papers, quote, estrogen loss triggers a decline in glucose metabolism, prompting an adaptive reaction to increase ketone bodies utilization. So the brain, as in the whole body, has to become better at using fat or ketones for energy. And to do that, this is the clincher, the brain requires the whole body to have good metabolic flexibility and insulin sensitivity to be able to mobilize the body fat and feed the brain. And in another study, Brinton found that, and this is also very confronting. I don't usually share this when I'm talking with the public because it's sort of, but it's important for clinicians to know if ketones are not available because of insulin resistance, brain cells may have to resort to cannibalizing their own myelin as a source of ketones, which is a scary thought. I mean, but the brain cells are desperate times call for desperate measures. And so this is part of the cognitive um, decline. So, decline is the wrong word. Sorry. Part of the cognitive sort of shifts that are happening, potentially deficits that are happening around this time. But this brain energy crisis should be temporary if all goes well. Both Brinton and Mosconi emphasize this in all their papers. So the brain and body can adjust and recalibrate to the lower estradiol via several mechanisms, including by adjusting receptors, like there's multiple mechanisms, but including by recalibrating metabolism to be better at burning fat. And that is only possible with good insulin sensitivity, which is why the insulin resistance of our modern age is a major, one of the modern factors that's making menopause transition so much harder. Think about it. I mean, our ancestors did not have to worry about insulin resistance. They were pretty metabolically flexible. Their brain, they could easily, start to shift gears to being more predominantly fat burning. That actually would have been pretty much a superpower for them, probably, because they could have, um, they could get by on less food in a way. So, okay, it's, as you know, insulin resistance is a common condition characterized by chronically elevated insulin and therefore a reduced ability to access fat stores for energy because it elevated insulin upregulate or sort of suppresses hormone sensitive lipase, the main enzyme that accesses body fat. So, unfortunately, as you probably know, insulin resistance is often missed in the clinical setting. That's because everything has been so glucose focused or glucose centric. I've got a new paper about this, which we can share with you as a bit of extra reading. It's specifically around PCOS, but I talked about the paradigm shift happening where all of this has to shift to being more insulin centric because insulin resistance cannot categorically pretty much be detected by blood sugar or HbA1c testing. Um, as you can see, blood sugar can be normal or even low at times with reactive hypoglycemia in the early decades of insulin resistance. So this image is from researcher Benjamin Bickman, who you probably know. I've heard him talk a lot about how the whole conversation has been too glucose centric. It's about insulin primarily. Um, and so, yes, we need to be on top of this. I'm going to show you a few slides about assessing insulin resistance. Um, all right, hope everyone's doing okay. I'm going a little quickly, but I am trying to get through the content. So, one more comment about brain recalibration. And that's according to, again, to Brinton and Mosconi, the researchers. So many women should come through this newly calibrated menopausal upgrade to, different kind of metabolic system, a different kind of brain, but in a good way. Um, but some women can emerge from this with an increased long-term risk of neurological decline. This is true. Um, this is a recalibration or tipping point. So this is a quote from Brinton. In neurological transition states, indicators of dysfunction at the limits of normal function can be signals of instability and tipping points. So a tipping point for health is a time of flux or change when small problems amplify to bigger problems in a way they just would not in a time of more steady state physiology. So the direction a woman goes towards health or towards disease is going to depend on multiple things: her underlying susceptibility, exposure to environmental toxins, things like this, but not all of it's under her control, but also how healthy she can stay during the recalibration process. And so we have to help people with this. So, long-term risk of dementia and mental health conditions is one risk. So is long-term risk of certain autoimmune diseases, especially Hashimoto's. I mentioned that. Long-term risk of osteoporosis and heart disease. And there's a great quote. So that citation I gave you there is from the U.S. study of women's health across the nation, who identified perimenopause as a vulnerable time for the onset of heart disease, and therefore calls perimenopause, quote, a critical window of opportunity for prevention. It's a really great way to reframe tipping point as a window of opportunity. All right, so let's go on to the third concept of reframing. Then I'm going to say a few words about assessment from my perspective. Then Adair is going to come on and talk a bit about functional testing. And then I'm going to come back for a quick overview of treatment. Right. So, final reframing. The early phases of perimenopause are a time of high estrogen, not low. This is absolutely crucial. So, this is just not understood out there. Like, and if you're a clinician, how many times have you seen someone come to you? She's already got super high estrogen, super painful breaths, heavy periods, all the fluid retention, histamine, all the high estrogen stuff, and someone's given her an estrogen patch. It's like, how is that helping? If they were also given a oral micronized progesterone at the same time, they might be coincidentally getting some benefits from that, but probably not from the estrogen. So this is Professor Pryor again. Professor Pryor's diagram. You might have seen this. It's been going around. She developed this. She made this diagram. It's schematic, obviously, but then I adapted it for my first book. It's quite a popular, or for my second book, Perimenopause book. It's quite a popular diagram. So you can just broadly, as you can see, it's estradiol's in pink. It's low in childhood. It's showing it's stable in the reproductive years. Of course, it is going up and down each cycle. And then during it's high and fluctuating in the teen years, fairly stable in the perimenopause years, and then high and fluctuating. And estradiol in the perimenopause years can spike up to 3 times higher than in the reproductive years. So it's no joke. Actually, it can go really high, and that does not feel good. And meanwhile, so estradiol is fluctuating. Progesterone is pretty much just quietly leaving the scene, as I say, it's just going away. Luteal phases are becoming shorter, they're often absent, so there's just not the progesterone there that to, counterbalance. All right, then it arrives at the stable low estrogen that is normal, not a deficiency, and but keep in mind, I know you know this, but all the cells in the body make their own estrogen, including their own estradiol. The brain cells make their own estradiol. It's part of how we recalibrate. Right. So how do you know if estrogen is high or low? Um, well, I would argue, actually, because it's hard to test estrogen, as you probably know, because it fluctuates through the cycle. And most people do not know, most patients do not know this, but you can explain to them actually, in a healthy menstrual cycle, estradiol drops to menopausal levels during the period. That is normal. In fact, during perimenopause, it doesn't go as low as it does during the younger reproductive years. So the way I do it clinically is you want to look for if estrogen has been overall quite high during the cycle, then you're going to have the following signs and symptoms. I don't mean high during the period because it's always low during the period, but if it's been high, um, then you're going to have heavy periods. Otherwise, the only way the uterine lining can build up enough to have a heavy period is under a lot of estrogen stimulation. Whereas if estrogen has been low, you're either going to, or if you're into that phase of perimenopause where you're not having periods, then of course estrogen is low. There's no buildup of the uterine lining. Moving down the list, if estrogen has been high, there's going to be that classic breast swelling. Professor Pryor says a great test for estrogen, this is very quite accurate actually, is to push straight back with the palms straight back onto the breast, like toward the body. And that kind of breast tenderness is specifically, it says that estrogen is high at that time. So it's a way to kind of in the moment sort of women to understand. If estrogen is lower, the breasts will feel kind of deflated, more deflated or flatter. Um, could be a relief actually if people have had a lot of breast pain through their reproductive years. And then if estrogen has been high overall, that's when you're going to get the night sweats, the premenstrual night sweats, because actually Professor Pryor also has a paper about this, explaining the night sweats and hot flashes. They're not from low estrogen; they're from the plummeting, the nosediving from sky high estrogen to kind of the normal menstrual low levels of estrogen. So the higher it goes, the farther it has to fall. Also, the other feature of high estrogen is often histamine symptoms, because in some, especially some women, depending on their immune system, high estrogen will trigger a mast cell reaction. So they'll get fluid retention, hives, headaches, irritability, because histamine is a neurotransmitter, is quite a stimulating neurotransmitter. Right. So in terms of assessing, beyond, okay, so this is very helpful I find clinically to just understand what the periods are doing. And even if there's no uterus, if the uterus has been removed, you can still go by fluid and breast pain and other symptoms like that. So, in terms of assessment, is someone in menopause, and kind of where in the stage of what phase of menopause are they in? So you're asking based on symptoms, is estrogen high or low? You've got the list of 9 symptoms that can be used diagnostically that I showed you earlier. Um, and also you can chart cycles. Sorry. So I'm sure in the audience today, there are going to be some people who are uh, cycle charters, teaching your patients about that. So the classic feature, and I would say what defines perimenopause in lots of ways, is the shortening of the luteal phase and the more and more and ovulatory cycles, or cycles where there's just pure unopposed estrogen and no progesterone kicking in. That's classic perimenopause. Beyond that, the other assessment I do is for general health. And this is actually really important because general health is what supports a healthy recalibration. So I'm not going to go through it. This is just for you to look at later. But I mean, obviously, these are all the classic things like um, you're looking for autoimmune tendency, you're looking for alcohol intake, you're looking for, and also to say nutritional status, you're looking for iron studies. Because with perimenopause, one feature is super heavy periods, like as in losing 400 milliliters per menstrual cycle, like per period, compared to the normal acceptable upper limit of 80, 400 versus 80. So some women are just like, and so there've been some studies come out to show that some of the brain fog of perimenopause is actually just the brain fog of iron deficiency. So don't miss that. Look at the aspect. You could look at a measure of aspects to do with the nervous system. I think that could be very helpful because it's a neurological transition. So think about heart rate variability. And then test for insulin resistance. And these are just a list of symptoms. I have a whole book about insulin resistance. That's my Metabolism Repair for women. Um, I'm just talking about here, like look for signs of fatty liver, hyperechoic liver on an ultrasound, pretty good, strong evidence of insulin resistance. And then waist measure, wish I had more time for some of this. I'll just say testing insulin itself, which I used to do more of, it's actually less helpful. There's some problems with insulin testing, which we can talk about in the questions, but there's actually just sitting right there in their standard pathology are a few markers that are very indicative of insulin resistance, like correlate quite strongly. So one is high triglycerides, high fasting triglycerides very strongly correlates with insulin resistance, and know that those triglycerides have been made in the liver from carbohydrates. Um, under the influence of insulin resistance. Also, another really useful one is high ALT, the liver enzyme ALT, especially in ratio to AST. On my Instagram a few days last week, I shared a study where they found, especially in women, a high ALT to AST ratio is strongly predicts insulin resistance. It's as predictive as a HOMA-IR index. So that's right there. I mean, it's inexpensive. You've got it. I'll just point out high serum ferritin can also be a marker. So there's a whole set of papers around how this is now more into the kind of the later phases of perimenopause and menopause, obviously, once periods have stopped. But high iron too high iron promotes insulin resistance in both men and postmenopausal women. Young women, that's one of the ways that young women are protected from insulin resistance, probably is the lower iron from regular bleeding. All right, good. Now, so I've tried to leave a bit of time. Adair, come on and do your we're going to do a few slides on functional testing, and then I'm going to come back and do um treatment. And I'll advance the slides for you, right? You'll have to just tell me next slide.
Perfect. Thank you.
Yeah.
So, Vibrance Cardiac Health Panel aids in detecting acute lipid, apolipoprotein inflammation, and myocardial stress markers associated with cardiovascular disease. So, it's going to include your standard HDL, LDL, including LDL direct, ApoA1, ApoB, that ratio, small dense LDLs, LP little a for genetic risk there. And then for inflammation markers, including oxidized LDL, MPO, plaque, and homocysteine, along with the myocardial stress marker, NT-proBNP. So this is just one of the panels that Vibrant offers. We also have the diabetes panel that includes ferritin if you want to add that to look at that marker. But that's Vibrant's cardiac health panel. So let's go on to the next slide. Thank you. Vibrant also is a hormone zoomer. This is going to include adrenal hormones and metabolites, along with hormone ratios, a 4-point diurnal cortisol, cortisone, and melatonin, well, creatinine. So everything's normalized here in creatinine, along with your sex hormones, estrogen, progesterone, testosterone, and the metabolites, and 13 endocrine disrupting chemicals and 2 bone health markers, and the oxidative stress biomarker 8-OHDG. All right, let's go on to the next slide. So this includes the sex hormone flow chart, which provides insight on estrogen dominance and also detox pathway. So let's take actually a look at an example on the next slide, closer up. So in this example, the patient has robust levels of androgens and upregulated aromatase enzymes, as you can see by the red and black arrows and bubbles there. And this is resulting in elevated estrogen levels, especially estradiol. So this is something you might see in someone who has heavy periods. The breast tenderness is an upregulation of the aromatase that's turning the upstream hormones into higher levels of estrogen that's then impacting the body, building more uterine lining um, during the earlier phase of the menstrual cycle. If we look at the next slide, we'll see that in this particular example, this person is favoring the yellow 1A1 pathway, as evidenced by the 2-hydroxy-1 level that's 3 times the reference range. However, this patient's not methylating very well, as evidenced by the 2-methoxy to 2-hydroxy ratio of 0.09. We want to be able to get some estrogen out of the body. That's what our liver does, get it out of the body. We don't just hold on to it all the time. We use it, then remove it, and then make new. And since her methylation activity is impaired, her estrogen metabolism is actually being shifted away from the predictive 2-OH pathway and towards the more dangerous pink 1B1 pathway, as evidenced by evidence of the elevated levels of 4-OHE1. And as we know, if not detoxified, that 4-OHE1 can actually bind to and damage DNA. So just another way you can use a hormone zoomer to look at risk for estrogen dominance there. In the next slide, we see the diurnal hormone graphs. If you're wanting to look at disrupted sleep patterns, this can provide insight on circadian misalignment. So in this example, the patient is having difficulty falling asleep due to elevated nighttime cortisol. And then at the same time, difficulty waking up due to low morning cortisol paired with elevated waking melatonin. So great insights into that circadian rhythm with cortisol and melatonin on the Hormone Zoomer. And then finally, on this last slide here, we're looking at the 13 endocrine disrupting chemicals like BPA, phthalates, parabens. For each chemical that's elevated on the Hormone Zoomer report, it's going to include a comment that explains common sources, symptoms of toxicity, and identifies all the hormones affected, and then also explains the mechanism of action. So just a shameless plug for Vibrad's Hormone Zoomer test, which is a great way to look at what's going on within in the body. Back to you, Dr. Briden.
Okay. Oh, you were quick. That was quick. Great. Okay. So we've got, I mean, I know I've technically got 5 minutes left, but I'm going to try to get through a bit more. Sorry, I'm just at the end of a cold. My voice is not holding out as well as I thought. So, a few treatment strategies. So one would be to support GABAergic tone. So a really main feature that happens, losing progesterone means losing allopregnanolone, which is the progesterone neurosteroid that stimulates GABA receptors. This is a huge part of the nervous system recalibration. So this is a place we can come in and help women. So all the things that can support GABA, I mean, regulating the nervous system, scheduling time for relaxation, getting more sleep, um, maybe adjusting work schedule, knowing that one thing that I say to my patients is that you're not always going to feel like this. So once you kind of pop out the other side and into your second spring or your energetic postmenopause phase, you could probably if you want to, you can dial the work back up. But this actually is a good time to sort of make more time for rest and for movement, because movement, the brain loves movement. The nervous system absolutely loves it because of lots of mechanisms, including, I'm sure you guys might know, something called brain-derived neurotrophic factor that's like a fertilizer for the brain. Quitting alcohol, I don't have time to go into all the reasons, except that it is not friendly to the perimenopausal brain. It's really not. It also increases the risk of breast cancer. Um, quite, I guess what I'd say around the research around alcohol and breast cancer is it's a linear risk. It's not a huge risk, but the research around it's really solid. So especially during these high estrogen, years, women are already, want to be thinking about, yes, healthy estrogen metabolism. And a big part of that is removing alcohol. And also I've found that the simple act of just stopping alcohol can, in some women, resolve all the neurological symptoms of perimenopause, pretty much all. It's not always that simple. Quitting alcohol doesn't have to mean quitting coffee. The two substances are not a matching set that has to be removed together. In fact, a moderate amount of coffee is possibly good for the nervous system, for the brain. Right. Also, supplements, my favorites are magnesium, taurine, glycine. They all work on the GABA system, B complex, and of course, body identical progesterone. So, or oral micronized progesterone or natural progesterone. As natural health clinicians, we've been doing this for decades, decades before conventional medicine kind of caught on to how much safer and better progesterone is. That's again, Professor Pryor's study there. That's a clinical trial she did that found that oral micronized progesterone significantly reduced the frequency and severity of night sweats and hot flashes in perimenopausal women compared to placebo. And I'll just point out that one of the big mechanisms is that body identical progesterone converts to allopregnanolone. And no progestin does that. Pretty much no progestin does that. And that also you can bring me back and talk about this, but I mean, that really does raise the question of why are we therefore routinely giving progestins to young women to switch off their own progesterone and, rob their brain of allopregnanolone, which is probably quite important for brain health. Also, progesterone does not appear to carry the breast cancer risk of progestin. The next general strategy would be to manage the high estrogen. So I talked about ways that the estrogen spikes can create symptoms. Well, certainly they can cause a histamine release. I talked about that. They can also, and histamine is anxiety promoting. And then there's the whole estrogen withdrawal. The higher estrogen goes, the farther it has to fall. So yes, we looked at estrogen metabolites. So really promoting healthy estrogen clearance through all the mechanisms, healthy gut, avoiding alcohol, perhaps things like calcium deglucarate, whatever other tools you have. Antihistamine strategies can be helpful, whether that's over-the-counter antihistamines, just as a trial to really see, how that works. Also, my number one antihistamine strategy, depending on the individual, but is often to avoid the normal A1 dairy or the dairy with A1 with inflammatory A1 casein can really calm down a histamine reaction. That's why it can help with premenstrual mood symptoms, and that's why it can lighten menstrual flow because there are a lot of mast cells in the uterine lining, and the sort of mast cell reaction there can also is a mechanism of heavy flow. Obviously, oral micronized progesterone is on the list again here to help to counteract and downregulate estrogen. I would also put it's not on the list here, but iodine is actually if you know how to use iodine safely, it's also quite a potent anti-estrogen. Next, I want to talk about something called the choline connection, and I'm going to share a paper with you on the next slide. Yep. Just because this is so fascinating. So later in perimenopause, once we truly are moving into the territory of lower estradiol, some of the neurological symptoms are from losing endogenous choline production. When I learned this, it was just like a penny drop moment. So that's because the PEMT enzyme that manufactures endogenous choline is upregulated by estradiol. And so less estradiol equals less endogenous choline, especially if you have a common SNP or variant of the PEMT gene, which about 1 in 4 people have. Um, for those of us who I have that, I have a homozygous. I have a personal story on this because when I read about this, sort of in that phase of perimenopause for myself, I thought, oh, right, connecting the dots. I've got homozygous PEMT, I'm lower estradiol, and so I did start taking some activated choline. And of all the supplements I've tried over all my 35 years, studying natural health and being a natural health practitioner, that choline supplement was one moved the needle more than anything I've ever seen. So it really can improve brain function. In fact, in one very interesting paper, which I'm about to show you, they argue that boosting endogenous choline may be one of the main brain benefits of estrogen therapy, which is so fascinating. I'm sure it's not the only one, but it's a big one. They say studies of estrogen replacement, cognition, and dementia risk have not considered choline supply from endogenous synthesis or exogenously from diet as a key moderating factor. Think about that exogenously from diet and the evolutionary mismatch. Our ancestors were eating so much choline from organ meats and eggs and um, brains potentially and seafood. And so our modern diet's quite low in choline compared to our ancestors. And just, thinking about it, yes, estrogen therapy clearly is a treatment for some women, a possible treatment. I'm not anti it at all. But for other women who can't or can't take estrogen or don't want to, it may be possible to just take choline. Finally, reversing insulin resistance. This is huge. You'll have to bring me back, and this is a lecture all on its own. I don't have time to go into any of it, but apart to say that improving insulin sensitivity is not, I repeat, not just about having the perfect diet and exercise. Instead, it's about working with a responsive, dynamic whole body system, which makes it perfect for natural health practitioners. That's the angle I took with my book is a troubleshooting approach to insulin resistance. Strategies that promote fitness or athletic performance are not necessarily those needed to recover from insulin resistance. In fact, sometimes it can be quite different approach. So, a summary of what we looked at, just a little few takeaways. Menopause evolved and is not an accident of living too long. Perimenopause is a recalibration and a tipping point for long term health. And the early phases of perimenopause are a time of high estrogen, not low. Let's finish with a beautiful quote from Professor Geraldine Pryor. Women need to know that the turbulent time of perimenopause ends in a kinder and calmer phase of life called menopause. Great. Only 4 minutes over. Got time for questions. I hope there are some questions.
There absolutely question. We've got one here from Lori White. She asked, can you explain deeper when giving progesterone, but it actually causes anxiety, mood issues, and they just feel worse? I understand the basics, but can you please elaborate?
Yeah, this is yeah, fair enough. I sometimes not preempt, but I sometimes acknowledge this right within the content. Some women just do not feel good on progesterone. It's important to keep in mind that the majority feel great on it. So there's that. Progesterone is one of these, it has a very complicated history. Um, I have a blog post called How Science Got It Wrong about progesterone. So it does have this sort of broader reputation historically of being bad for mood. That is incorrect. Progestins are usually bad for mood. body identical progesterone is usually good, but yes, some women get a negative reaction to it. I think it's a few things actually. I'll just uh, detail a couple of mechanisms. I think, well, certainly progesterone also has the feature of upregulating estrogen receptors. That will take place over a couple days. So some women can get sort of an increased estrogen sensitivity when they first start taking it. So that you want to sort of troubleshoot that and see, depending on how bad the negative reaction to progesterone is, you might want to sort of push through or sort of just see if they can get past that. Or yeah, um, give it when estrogen at a time when estrogen's not quite so high, possibly. But the other aspect of it is that it's to do with the GABA receptors. So it's the GABA receptor. So allopregnanolone, natural progesterone's metabolite, interacts with the GABA receptor quite strongly, usually in a good way. But depending on what's going on with that individual and sort of genetically, and also how much sort of histamine and inflammation are around, the GABA receptor can respond quite differently. The GABA receptor, I mean, I could give a TED talk on this, but it actually, the GABA receptor reconfigures throughout the whole menstrual cycle because it has to, right? Because progesterone goes up and down. In women, progesterone increases by 100 times during the, um, I think it's actually more than that. Actually. Maybe I've got the number wrong. Progesterone increases dramatically, way more than estrogen increases. Actually, it's not 100 times. Sorry, it's about 20 times. And because of that, the GABA receptor would be exposed to vastly different amounts of progesterone throughout the cycle. So it will calibrate itself to be like calibrated for low progesterone and then calibrated for very high progesterone, sort of less sensitive, and then back down. And I think some women, their receptors are just not doing that. So sometimes it can help. An antihistamine strategy can help. Sometimes they might just not be able to take progesterone. I mean, so there is the reality that some women need to think about other options for progesterone. Natural progesterone isn't the only option for perimenopause. There's other ways to sort of manage symptoms. Does that answer the question? Hopefully that answers the question. There's a lot. That question has a big answer.
That was perfect. Thank you. On
Yeah.
a good note, just want to point out that Vibrance Hormone Zoomer does look at both alpha pregnandiol and beta.
Yes.
Yeah.
Yeah. So you guys don't measure allopregnanolone, right? But you can sort of infer it from other ratios. Do I have that right?
Oh, good question. Good.
Because my understanding is, okay, so actually this will help people to troubleshoot it and think about it. Part of the conversion of progesterone to allopregnanolone uses 5-alpha reductase. So you can detect with some of this functional testing. I'm pretty sure I don't use a lot of it myself, but I know you can detect the activity of 5-alpha reductase based on other markers, and therefore you can sort of infer allopregnanolone production. And this competition for 5-alpha reductase, because as people know, I think I've got the name of the enzyme right. That's the enzyme that converts testosterone to DHT. So this is why progesterone has an anti-androgen, beneficial in women anti-androgen effect, because it competes for the enzyme that's also activating testosterone. One other thing to say, actually, sorry about the progesterone sensitivity. A lot of, well, clinicians and also people on my social media are telling me that you can, women who, it's weird, but actually women can sometimes get a more negative reaction to a lower dose of progesterone. And if you go higher, you kind of have to hit the sweet spot for their GABA receptors. If you can actually go up with the dose and actually find they tolerate it better. That's particularly with the oral progesterone.
Mm,
And depending on the severity of the negative reaction, some women aren't going to be willing to it requires a bit of trial and error to find out what's the right dose for them. But that can be worth doing because some women, even though they think they can't tolerate progesterone, they actually can.
there
They
we go.
can find a way to do it. Yeah.
Perfect.
Okay.
Next question from Lindsay. Thoughts on supplementing directly with GABA?
Yeah. I mean, I have never had great success with it, but my understanding, and I'm happy to have people in the audience chime in, but my understanding is that the supplements don't really cross the blood brain barrier. So there's sort of other ways to use things that do. But yeah, I mean, that's sort of my general, but I mean, some people swear by it. So I think actually, I mean, some people say, and I don't know if this is true, but I mean, so you know how there's obviously intestinal permeability is a concept we're all familiar with for decades now. There's also a concept of sort of blood-brain barrier permeability, and how some people, it's not necessarily a good thing, but I sort of had heard that potentially people who can get a good reaction to GABA may actually have a higher degree of permeability of the blood-brain barrier.
Really?
Um, hope I've got that right. I'm not an expert on using GABA, so I hope that answer has been helpful. People can fact check that.
Right. And then one final question from
Oh yeah,
Heidi.
okay.
Do you have
Yeah.
any tips for women who have PCOS who are also perimenopausal and want hormone replacement therapy?
Right. Okay, so the thing about PCOS, which might be having a name change soon, which I think would be great, but yeah, that's sort of syndrome of high androgens, irregular ovulation.
Mhm.
Classically, it will if women So classically, women will tend to outgrow some of that. So what we do, I mean, because the cycle shortens as we get as we move into perimenopause. So for women with PCOS, they can actually shorten to like a normal cycle. So I've had women with a history of PCOS in perimenopause. You're like, oh, I'm having 28-day cycles for the first time in my life. Like I was always like a 40-day cycle person. So, and also androgens. Overall, androgens do tend to decline. Well, not tend to. Androgens decline with age in both men and women. So some of the androgen symptoms will lessen, although then there is a sort of a new relative androgen excess of perimenopause that plays a role in the shift to insulin resistance. So it's a nuanced picture because some aspects of the classic, PCOS picture improve, and some aspects can worsen. And the part that can worsen is insulin resistance, and sometimes the androgen excess, despite lowering androgens. Um, so the tip would be, I mean, I don't think there's not a specific method of hormone therapy, and I don't use the word replacement therapy because it's not accurate for menopause. It's not, um, it's from a scientific perspective, it's using, hormones to get better outcomes and relieve symptoms, but it's not, technically replacing something. But I think, yeah, there's no one size fits all for PCOS. I think like anything you would want to assess the individual. And I would just say, like, generally, if a woman's in the high estrogen phases of perimenopause, if she's having super heavy periods and breast pain and close together cycles, regardless of whether she has a PCOS history or not, that's a time for progesterone only. Um, and then later, staying on the progesterone, um, assuming she can tolerate it. And then later, when the periods are lengthening out a big, 90 days or 100 days or 6 months between periods, then yeah, that'd be, or even maybe before that, time to come in with a bit of estrogen therapy. Body identical estradiol is the classic. Everyone knows, right, that the whole, like, it's interesting from a naturopathic medicine perspective, because in the 90s, when I started practicing, my main practice, I pretty much built my practice on taking people off Premarin and Prevera, the old, I mean, some people in the audience might not even know what those are, the old school HRT, and putting people on body identical hormones, which you had to get from a compounding pharmacist back then. I mean, you could still get them from a compounding pharmacist, but now, thank goodness, I thought it would happen faster than it did. It took 30 years, but now the standard hormone therapy is body identical. So the classic estrogen patch would be body identical estradiol, which, if you're going to take estrogen, is pretty much, yeah, the right one to take. So yeah, that was a much broader answer, but hopefully that answers the question.
That covered a lot of different topics all at once, and it was perfect. Yeah, the main takeaway is that anytime you have estrogen, progesterone that aren't balanced, it's gonna cause more symptoms.
Yeah, I mean, and also, I guess another takeaway would be, if you're going to take estrogen, you should always take progesterone with it, and that would be even if you don't have a uterus. And that is because, yes, every tissue in the body, the brain, the breasts, they need both. They do need progesterone to counterbalance
Mm,
um, estradiol. Estrogen's a very stimulating hormone, and it needs a companion to calm it
mhm.
down.
Mhm. Yeah, like sodium, potassium.
Yeah, yeah, good analogy. Yeah.
All right, well, that takes us to the end of our time today. Dr. Briden, oh my gosh, thank you so much for this enlightening webinar. Audience members, thank you so much for joining us today, for your questions. And until next time, everyone, stay vibrant. This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.